Hi, and welcome everyone to today's Leadership in Action webinar series. We are so excited to have Dr. Omar Galárraga here today with us as our guest speaker. Omar, incidentally, was my faculty advisor when I was a student in the in-person program back in 2015. So I'm so glad I have the opportunity to hear from him again and hear more about all of the wonderful things that he's been up to since I've last had a chance to really talk to him in detail about his work. So Omar is a little bit about Omar. Dr. Galárraga is a health economist and a health services researcher. He is the director of the Health Service Research Doctoral Program at Brown University. So for those of you interested in PhD at Brown, feel free to connect with Dr. Galárraga. At Brown, he also serves in the steering committee for the Population Sciences and Training Center and on the advisory committee for the Center for Latin American Studies. His research uses insights from health and behavioral economics with a special focus on HIV treatment and prevention, health systems, and applied health econometric analysis. I'm sure we're going to hear a lot more about specifics about Dr. Galárraga's work in a little bit, but I'm going to turn it over to our moderators today. Sean McLean, maybe you can go ahead and introduce yourself.
Hi, yes, can you hear me okay?
Yes.
So, hi, my name's Sean McLean. I'm a member of the online MPH class of 2025, and I currently am calling in from New York City right now. So a little bit about myself. I, started the program a couple years ago. I really enjoy my time here at Brown, but my interest in public health goes back about 12 years. When I was a teenager, I began volunteering in emergency medicine, and went on to volunteer and work in the emergency medical services field for a while. Held an officer position for a bit at a volunteer emergency company during my undergraduate experience. And from that, that kind of shaped some of my educational interests, especially my work in public health with a focus on social determinants of health and international healthcare. Latin America in particular has been a big focus of mine during my undergraduate experience. My senior thesis was a case study I conducted on emergency medical services in Nicaragua, partnering with a health clinic there in Nicaragua to conduct some research. So my dream is to eventually take my public health experience into the international world, working abroad in the nonprofit sector, particularly focusing on structural and social determinants of health. And I'm just very excited to hear about the different experiences that Dr. Galárraga can share with us about his work. So very happy to be here.
Thank you so much, Sean. And Sham, can you introduce yourself as well, please?
Shah Madhusimili. I've been in healthcare for 30 odd years, mostly as a technologist and focused on sustainable social change. Have worked all around the world, primarily in the US, but UK, Australia, Singapore, some work in Africa, some work in Southeast Asia. Been very interesting journey so far. And my interests, now that after 30 years, I'm dabbling back in academia, are in comparative health systems. I focus on the intersection of primary care and SDOH, community care hubs and building community capacity, structurally and socially, and circles of influence on how to modify health behaviors. Very nice to be here. Nitya, thanks for having me. And Dr. Galárraga, really looking forward to hearing from you on your journey and learning from it.
Thank you so much, Sham. So, just again to highlight, our online MPH program has students with a minimum of 2 years of work experience, many of whom have an average of somewhere around 10, as you can see from our wonderfully accomplished moderators today. They come from a diverse range of backgrounds. We have clinicians, we have healthcare workers, we have people who are in tech, like Sham has said. We have people from banking, finance, education. So we have a whole range of people in our program, and each of them brings their own individual perspective to the program, which makes it a really strong one, in my opinion. So I'm going to turn it over to Sean to take it away with the questions for today.
Okay, sure thing. So, for the first questions here, well, I do see, Sham, you wanted to ask about the why public health. So, did you say Sham or Sean, Nithya? I apologize.
Either way.
Either. Well, yeah.
Okay, Sham, why don't you take it away? Because I saw you had a question to kick it off. So,
Yeah, I think it's a very, very simple question, Dr. Galárraga. Why public health? Why reproductive justice? Why you?
Thank you. Thank you, Nitya, for the kind introduction and for the invitation. It's a pleasure to be here. Nice to meet you, Sean. Nice to meet you, Sham, and hello to everybody now and online. Again, my name is Omar Galárraga, and I'm a faculty member in School of Public Health. I've been there since 2010, but you know, the answer to that question is really related, I guess, to my background. You know, I was born and raised in Ecuador, and I discovered economics very early on. And so I took my first econ class when I was in high school. Actually, I was very lucky to be in a very competitive, very academically rigorous high school. And I was 16, maybe 17, probably 16 when I took my first econ class. And also somebody that I was friends with in my neighborhood happens to have a father who was a famous economist, and I learned from him as well, and I got hooked from very early on. And so my dream was to study economics in the US. And so I was lucky to have family in Washington, D.C., and I was able to, you know, I did one semester of economics school in Ecuador, and then I migrated to the US, and I did my undergrad and master's in D.C. and worked for 5 years in DC, and my first job was health economics, and I think it happened because you know, in my last year in undergrad, in my senior year, I took a health econ class as an elective, and I liked it. And my first job was as economic analysis program manager for micronutrient interventions, and so I had to learn, you know, about RCTs, and I had to learn, you know, they don't teach you that, or they didn't used to teach you that in econ school a long time ago. So maybe now they do, but especially in development economics, but back then, no. So I had to read the Lancet on my own to teach myself. And I was reading that, I was just like, wow, this is really cool. And I really like that. And so that's how I became really involved. And after that, I got a job at Mathematica Policy Research. And after that, I was very lucky to be hired by the UN. So I was 2 years in Ethiopia working for the United Nations Economic Commission for Africa. And then I felt like I needed more tools. And so again, I was very lucky to get accepted into the health economics program at Hopkins. So I went back to grad school, and I was in Baltimore for 5 years. And then my first job actually was in Mexico. So I was at the Mexican School of Public Health from 2006 to 2010, before coming to Brown. So, you know, I like you, Siam, I've been in a few places, and I think that has informed my decisions from very early on. So, you know, I grew up middle class, and, you know, my family, at least my generation, never experienced poverty. My parents and my grandparents' generation, yes, I mean, sometimes I hear that there wasn't enough food in the table, but by the time I was born, you know, the oil boom had happened, and there was a strong middle class. And like I said, I was very lucky to have access to very good education. But I did travel around the country, and I saw a lot of poverty. So I think economics opened the eyes to me about the importance of investments in health and education, and how important that was. And so that was always in my mind. And that's why also thinking about sexual reproductive health, especially for young women, where I grew up, you know, the teen pregnancy is a big issue, especially among indigenous women. And so we've been working in that area. We have a pilot project right now with some colleagues in Ecuador. And so it's been a long trajectory, but really informed by, again, where I grew up and in the circumstances that I was raised, and what I saw as a kid, and just trying to help out any way I could.
Impressive, Dr. Galárraga, and a Sean, please. For you.
Yes, Absolutely, yes. So thank you so much. Very insightful, and actually segues directly into some of the questions I had. So, the first question, I guess, to kick things off, is how do you think your background has shaped your focus on addressing particularly the structural determinants of health inequalities, and how that there's the intersectionalities with reproductive justice in that sense. And if you're okay with me also asking on a personal level, of the countries that you have conducted your research in, because you've researched throughout the world, you experienced the UN and Africa, everything. Which has stood out to you the most in terms of the intersectionality between structural determinants of health and reproductive justice, if I may ask?
Mm-hmm. Well, there's always the issues of the structural issues, but they're complex, and so it's been very difficult, I think, to come up with very rigorous, large level structural interventions in the public health that are effective. And so again, when I was even, I think 1998, 1999 is when the Mexico Progresa Oportunidades conditional cash transfer program came about. And I remember, reading about it and again hearing, oh my goodness, this is an RCT. And around the same time, I had taught myself what an RCT was, right? Because I was working in vitamin A, iron, iodine supplementation, and the economic returns on that, some modeling work. But then like I said, I was self-taught in terms of an RCT. And then I realized, oh my God, in Mexico, they are doing an RCT for conditional cash transfers. And so that was very impressive to me because they were really trying to address poverty, which is what I was interested in, because that's what I grew up with. It's like, how do we solve this, right? Because the cycle of, you don't save a lot, you don't invest a lot, and then you cannot have enough money for education, health, and then you don't make a lot of money, and because of that, you don't save a lot, you don't invest a lot. So it's a circle that you want to get out of. But it's very difficult, right? If the structural issues are not dealt with. And so when Mexico did the conditional cash transfers program that were in place from about 20 years, the current president took them out, I think in, 2020 or something. So they were about for 2 decades they were there. But when they first started, I was very impressed with that. And so my first job going to work in Mexico and working with some of the people that were working on the initial experiment, I really felt like, okay, well, you could make a difference, where the government is willing to listen to the researchers, and so that was very eye-opening, and also a very sort of bucket of cold water reality, because you see, I proposed to study HIV in young people. That was my interest. But then I realized once I had the data that luckily for the young people, HIV wasn't very prevalent in the general population. Unlucky for me, because it's like, oh my God, I don't have enough sample size. What am I going to do? So I switched then to men who have sex with men. And eventually I switched into male sex workers populations, which because of the work they do and because the market inducements are such that condomless sex is paid more, then the market inducement is for unprotected sex. So there is a lot of HIV in these populations. And so that's where we switched. And working with these populations, for a number of years. I've started working there from, 2008. So we've been working for a long time now. So that has been a good experience at the intersection.
Oh, that's fascinating. So thank you so much for sharing about that experience. That really addressed both of the questions there. So thank you so much. As we've mentioned, your work spans across countless different disciplines or countless different backgrounds and everything, but also across both quantitative and qualitative lines. So I guess my follow-up question to that is, what factors did you have to take into consideration when you chose to like pursue, these different backgrounds, particularly when you made your shift into looking at reproductive justice and then also looking at the populations you mentioned, and I know this is a very broad question, but do you have any advice that you might give to yourself looking back, 2008 or even earlier in your career, when you were like, looking at exploring and applying for graduate school, even so, going back even further, that you wish you had known based on what you learned through this experience in Mexico and beyond? So.
Yeah, first of all, I'd like to say that my own expertise is just quantitative. I studied econometrics, and that's what I used. I do work with qualitative researchers that are my colleagues, and I rely on them. And I love medical anthropology. I like the way that they observe and the way that they do interviews and in-depth interviews and qualitative work. But that's not my expertise at all. I mean, I'm just I'm always learning from them, and so I think that the key for me is to always learn methods and to think of it as a toolbox. Certainly within my field of applied econometrics, there's always new tools, and you need to retool. And you need to think carefully about what is the appropriate tool for the problem at hand. And sometimes, of course, qualitative versus quantitative. If you have both, that's great. But for me, it's always a matter of just having the right team. If it's a qualitative issue, then I have to usually include a qualitative colleague to take care of that part. Yeah, when I was applying to school, the first time that I applied to grad school, I think I just applied to one school, and that was a mistake. It's a very prestigious one school, and of course I didn't get in. So that was a mistake. Luckily, afterwards, I was given some advice, and I went through some people at Institute for Recruitment of Teachers, which is a very, very good program, IRT. And part of the Andover Academy, and I was accepted into that program, and that was great. And they helped me out to craft my statement and to apply to 10 schools, and they helped me pay for the fees. And I think then I got 10 out of 10 or something like that. It's just the difference of just sort of packaging, it's just sort of how to present yourself. And of course, it's a numbers game, right? I mean, applying to I was lucky to be accepted into all of them, but when you just apply to one or two or three, it's just the numbers are not with you. And when you are, basically ask questions to those who have already gone through or through a system that helps you, really prepare yourself. But, you just learn by mistakes sometimes, trial and error.
Absolutely.
That's fascinating. Yeah, and I really relate to what you mentioned with how between quantitative and qualitative, it's all about having a team, because that's one thing I've experienced here at Brown. At my time so far, there's so many people, as Nithya mentioned, from different backgrounds and different specialties, and everyone has their area of focus and expertise. And together with the teamwork, especially with like group assignments, it's amazing to see all those come together. So that really resonated with me. Thank you. I'm going to pass it over to Sham now, who has some other questions. But thank you so much. That was really fascinating.
Sure. Yeah. Thank you.
Thanks, Sean. And Dr. Galárraga, I just want to echo what Sean said. In the online MPH program, it's been compressed learning for all of us because we have such a broad cross-section of people. And as we all collaborated, it's reinforced that notion of team and getting those perspectives. The question for you is, starting in Ecuador and your journey through DC. So you worked in the intersections of academia, industry, policy, governments. So how has your perspective evolved? In your mind, what changed?
I think that what has changed to me lately is just this idea of not just being precise, but also being relevant, right? I struggled for so many years to get the tools, to get the science, and to, craft these, very precise experiments that then may not be relevant, right? Because, I don't know, industry doesn't care, the government doesn't care. And so I think that, to me, over the years, I've learned to think more carefully and strategically, and I'm still trying to do that more, so that what we do has more policy impact. And I think that's, that's related to the first question, right? Why public health? And I think the idea there always is like, how do we maximize the policy impact? And I think as researchers, we need to think very carefully in terms of what sort of research we go into and what sort of programs we analyze and what sort of interventions we test. Because if these interventions don't have any legs with industry or with government, or sometimes even with communities, then why are we doing this, right? It's just sort of an exercise in futility in a way. And so I think that I was very naive, when I started this, I don't know, 30 years ago. I just thought, oh, economics is a great science, and they run these amazing tools, and they do this fancy math, and I just wanted that. It's a shiny object. And but then you think, who's reading your papers? and what impact are you having? And so I think that's a reckoning that has little by little come to me, and we're trying to again be more relevant, not just very precise and scientific.
Let me. It's interesting you mentioned the intersection between interest and relevance. Of course, you want to do things you like, but of course, you want to do things that other people care about, right? So what will be the focus for the next 10 years for you? Obviously, things are evolving. There's a lot going on around the world. If you could please share your perspective on what would you focus on? What do you find relevant?
Yeah, I think that there's so much negativity around the world from public health, and there's so much misinformation, and there's so much I don't know, lack of valuing science, which is very unfortunate. And so what I've been trying to focus is shining light on the things that do work. And so, for example, we just published an evaluation of a expansion of primary care in Ecuador, which is called Programa Médico del Barrio, sort of neighborhood doctor program, which is just this very basic idea that you have mobile teams with basically a physician, a nurse, an information technology officer, and you go to peri-urban and rural areas where the most disadvantaged populations are, and you do basically screening tests, and then you do referrals, and then we do some basic econometrics, and we show that indeed access to preventative care has increased, and people are reporting more about their health problems. Obviously, you cannot change the structures, right? So we don't find access to apologies. We don't find access to curative care has changed, and so again, you run against the structural factors, right? So maybe the neighborhood doctor was able to screen that the person X had hypertension, and maybe they did some preventative, but in terms of, I don't know, lifestyle and diet. But if I do want the medicines, I do have to go get the statins and the pharmacy, and sometimes that's difficult, or there's stockouts, etc., etc. As you know, in many low and middle income countries, this is a problem. And so yet there is something there, and I think that that's again something that we want to do more of, these sort of evaluations of things that are working, just to give policymakers something that they can say, well, this is evidence, and this is hopefully rigorous evidence that this is work. We should do more of this. And yeah, that's the sort of thing that I think is more needed. Again, shining light on things that do work, so that hopefully there is, there's more light and less heat, because there seems to be a lot of heat around and it's just not useful.
No, just a quick follow-up on that. It's I'd love your perspective as an economist, right? When you look at countries like Ecuador, Cuba, even countries like India, the health worker program in Ethiopia, where there's, by necessity, some would argue, a fundamental focus on primary care and preventive care. Whereas in the US, we seem to be talking more about a lot of specialized things only a few people can pronounce. So would love your perspective on that intersection, if you will.
Yeah, I think that the public health science has been very clear on that for at least 20 years, right? I mean, I did train at Hopkins, as you heard, and one of my professors was Barbara Starfield. And so, I heard from the master, herself, that, primary care and access to primary care is very, very important, individual and the population health level. So we've been able to demonstrate some of that in our work ourselves. The only thing to be careful with, I guess, from an economics point of view, and I know you mentioned Ethiopia, for example, sometimes we have to be careful because a lot of the community health workers are really community health volunteers. And oftentimes they're women. And what this means is that you have a lot of women that are being asked to do a lot of work with no pay. And so I think that we have to be very careful with that in countries, and especially in Ethiopia, where I remember this was an issue some time back. I don't know if they corrected that, but certainly it's an issue in many countries. So we have to be careful just to make sure that the healthcare force is duly compensated for the work, the important work that they do.
Very, very important perspective, and I completely agree on I wouldn't quite call it exploitation, but sometimes it does get close in that context. Sean, I know you had a few more questions.
Yeah, it's very interesting, actually, and thank you so much again. Very insightful, and I work with volunteers very frequently in my career. I work for the American Red Cross, and I help manage a lot of volunteers here in New York, and I understand how important volunteers are, but also how important volunteer welfare and the looking out for volunteers and being mindful of the fact that is unpaid work, and we need to value and appreciate that. And I think that we have been seeing a societal shift towards, the appreciation of, the value of both volunteers and just in general. We've been seeing a societal shift in discussions around, a lot of these topics we've discussed today, including sexual health advocacy and education. So it's clear that, the fields that we work in are continuously evolving to meet the needs, especially the needs of diverse communities. So I guess now looking forward at the future, as you mentioned, being mindful of these different factors, how do you envision the future of sexual health advocacy and education evolving within the next, say, 5 to 10 years? And what role do you see yourself playing in it, looking more broadly?
Yeah, I think personally, it's again shining light on what works, but also the other side of the coin, right? Also shining light on what doesn't work. And so we have done things like that. And again, I'm giving another example from Ecuador. 2-3 years ago, we published a paper in Economics and Human Biology about the negative consequences on teen pregnancy, especially among indigenous teens, of a restrictive policy for sexual reproductive rights. And so the president then, President Correa, had been already elected twice, and then changed the constitution, was elected a third time, but then he couldn't be elected another time. And so I don't think he cared about showing his, true colors in a way, and his true feelings about sexual reproductive health. He was self-professed Catholic and was very much in line with the religious views, the very conservative religious views. And so he changed the policy such that the program that was in place, providing adolescent-friendly reproductive health, sexual reproductive health services for teens, was removed. And so, we showed the negative impact that had. Again, using applied econometrics techniques and, publishing in an economics journal. So I think, to me, that's the contribution that I can make, having the best either experimental or rigorous non-experimental or quasi-experimental designs to show what works and what doesn't work in sexual reproductive health. And we continue to do work, in Kenya, in Mexico, in Ghana, and South Africa. Also, we've been lucky to have funding from the NIH, again, to improve prevention and treatment programs around HIV. And usually what we do, our competitive advantage, of course, is economic-based programs. And so these are incentive-based or insurance issues, or now we're dealing with microfinance issues in Kenya, as well as, behavioral economics nudges. Sometimes something simple as a reminder, something simple as an opt-out option, something simple as a default that actually changes what people do and what providers do. And so, and is not as costly. So we're looking into a lot more into that. So that's the space that we're looking at. It's the EAST framework. So sort of making it easier, making it more attractive, especially for young people, making more social, and make it more timely. So this is the acronym, I think, that is being used, EAST. And so we're thinking a lot about that. That is not just about incentives, because sometimes those cannot be sustained in the long term, because even the program that I thought was going to be there forever, Progreso Oportunidades in Mexico, lasted 2 decades. But after that, it lost political will, right? And if you lost political backing, then it doesn't matter that it had been evaluated. It doesn't matter that it had been shown that it had positive effects in a lot of things. It was scrapped. And same thing with Seguro Popular. Seguro Popular, we evaluated the popular health insurance for the poor in Mexico, that we also showed a lot of positive effects, not only in reducing catastrophic and impoverishing health expenditures, but in actual health outcomes and reductions in infant mortality. And so now that they've scrapped it, now I'm working with a student, Rachel Rosales, a doctoral student, and we are showing now that that reversal actually has negative consequences on child mortality. And it's unfortunate. It's unfortunate that sometimes politicians say, okay, we're for the poor, we're for the children, but the actual policies actually are the opposite. And I think it is our duty as public health researchers to show the truth with very rigorous methods, and in a very dispassionate and political way. I don't care that they are from the left or from the right, whether they're populists or not. I just want to see what they do in public health and sexual reproductive health and see if it works or not.
Wow, that's really fascinating, and I'll have to look up that acronym more later, the EAST acronym. But it is fascinating you bring up the kind of backsliding, so to speak, of some, procedures and policies that have changed. We will actually. I have some follow-up questions on that, but first, I would love to just pass it over to Sham. Had another question to ask, but I would love to return to that later in the discussion. So thank you so much for sharing that. So,
And I'm actually going to modify what I was going to ask and build on what Dr. Galárraga you're talking about with teen pregnancies. If you look at the teen pregnancy context in your work in Ecuador, in Mexico, in Ghana, and let's say teen pregnancy in the US, in New York, right? How do you the political context and what is happening in Ecuador is very fascinating, right? And we are doing where I work, we're doing some work on incentive-based pregnancy literacy and pregnancy social intervention type of programs. If you could share with us your perspective on economic evolution and how that seems to change or not change the societal conversation around reproductive justice, around teen pregnancies, because some of these countries are getting richer, you could argue. They now have a more sustainable middle class. Love to get your perspectives on that.
I think that, in terms of incentives for behavior change, and I think in terms of conditional cash transfers, these are programs for the poor, right? And these are programs usually trying to prevent teen pregnancies, and these are programs that allow young women to continue studying, right? And so they can finish high school or they can go to college, and that allows them to to have a better income and to have better living, and then hopefully when they want to decide to have a family, then be in a better position to do so. I think the economic evaluation around there is first of all based on the effectiveness, right? So I know that in India they've done a lot of conditional cash transfer programs that have been evaluated, very positively, very well. They work. Of course, they're not free, these programs, but I think the social return is a positive return on investment, and perhaps more of that needs to be done just to show that. At the level of society, these are worthwhile investments because you're not just preventing a teen pregnancy, but you're allowing more human capital investment, right? Because again, these women finish high school, they go to college, they get better jobs, they have more income, they're more productive, they can contribute more to society. And if you just do some simple cost benefit on that, society comes out ahead. And so I think that more work needs to be done around there, just to show that this is worthwhile, that this is a good bang for the buck, so to speak, at the societal level.
And I think that's a fascinating perspective for a lot of us who work in public health, who don't quite always think through the societal impact and the economic impact that the interventions we're working on can have. So that's thank you very much for sharing. If I may switch to a slightly different focus, you mentioned a couple of folks that you worked with who are legends in the field, and we think of you as one as well, and some of us will work with you and learn.
That's so kind.
Oh, very, very deserved. Who shaped your career, Dr. Galárraga? Who are the people, if you look back from when you started this journey, who made a difference, who changed, who shaped your thinking?
Yeah, I think that I've been a very curious person from very early on. So I think that, again, in terms of economics, I could go back to, I had a high school teacher in economics. But even prior to that, I remember that we took a course on, I don't even remember what it was called, some sort of advanced algebra or something. And I remember, starting to look at Cartesian distances and how you do, a point X, Y, and then you do the distances, and just being fascinated by that sort of mathematical thinking and how precise you could be. And so even in high school, like I said, I was very, very lucky to have very good teachers. And even just my fascination with reading and writing, I mean, it came from, it was funny, but I went to the Jesuits, and they were very rigorous. And I remember they thought they taught me to read and write. It's like, what does it say and what does it mean? And then you write it, and what do you mean and what are you saying? And so that was very good. And then again, in undergrad, I was very lucky to be in the honors program. I came almost penniless as an immigrant, and so I went to a public school, and I was very lucky to be in a country like the U.S. where there's good public schools. If you devote yourself to studying, you can find things. And I found health economics that way. I found an elective and just had to read the book myself, but it was great. And so I think that just having those teachers in public schools is very important. So I was very happy actually when I was in Mexico. I had joint appointment with UC Berkeley, which of course is a very good public school. So I was very happy to be part of that as well. But just in terms of my, really professional training, I mean, I owe a lot of how I think about things to my advisor, David Salkiver, who's a mental health economics expert. And of course, the person who trained me in econometrics is Robert Moffett at the economics department at Hopkins. And he was, a giant. He was the editor of the American Economic Review for a long time. And, I took his class twice, one for credit and then just as an auditor, because there's always more econometrics to learn. So microeconometrics was my favorite class. And now that's what I teach. I teach basically an applied microeconometrics class, is applied econometrics methods to public health. I consider myself a lifelong learner. So, I'm always trying to learn new methods. And I think that just, comes from, I don't know, being curious. And so I don't think there's just one person that has shaped me. It has been many teachers, many colleagues, many students. You learn from your students. And so our students at Brown are so smart. I'm always learning from everybody. And so it's just a perspective, I think, on just, again, trying to grow, but with the idea, not because we want to be great, we'll never be great, but just because we want to help, right? We want to do something, and again, shine the light on the things that work and shine the light on the things that don't work. And hopefully policymakers will do more of what works. And then hopefully people will have better lives and healthier lives. And so that's, it's a very practical approach, in my opinion.
And I think the practical, pragmatic way you approach public health has been a theme in this conversation for sure, and really appreciate you sharing that perspective. I know Sean and I had somewhat similar questions. Every generation they think they're at a historic moment. You could argue that every generation creates a historic moment, if you will, right? And there is a lot of positivity, there's a lot of technology, a lot of interesting things going on, but there's also a lot of negativity, a lot of divisive thinking. And if you look at our online MPH class, being parochial for a second, that's what we're getting into. When we graduate, and quite a few of us will this year, what's your advice to us? This Brown is very comforting, it's supportive, it's open, and then there's the real world, right? How would you think we should approach it?
Yeah, what I've learned is that, again, it's good to be part of a team. It's good to be part of a multidisciplinary team. I have myself always, like the quantitative approach, and again, sort of the applied econometrics approach, and that's what I've specialized in. But again, working with young people that know how to do Twitter and how to do X and how to explain it to the regular folk, to the general audience. So the paper I mentioned that just came out, evaluating the Médico del Barrio strategy, was published in World Development, and it has some econometrics, so very few people can probably understand it. But one of my collaborators, he is a very bright young Ecuadorian who actually just got accepted into a PhD program, but he's able to talk to general audience. So he divided, and he did like one of those series of tweets. I think he did 5 or 6, just sort of breaking down and putting it into general terms, and that was very, very successful. I've never tweeted something that has gotten so many reactions. I mean, I was just like looking at my Twitter and like, wow, my goodness, there's like 400, 500, which for me is like amazing, right? I mean, posts on this, and it's because he's able to talk to a wider audience. And I think that's very important, right? That either we ourselves learn to talk to a broader audience, or we team up with people that can talk to a broader audience. Because again, I was trained as a health economist, and I was trained to be a very exact, scientist. But that's not enough in this day and age, right? We live in this post-reality world, right? People think whatever they think, and they just are in their own bubbles. I mean, just like we are in the brown bubble, there's other people that are in other bubbles. And so how do we get out of that? And how do we make sure that hopefully we reach a wider audience, and again, we reach a wider impact, because that's what we want. We want better health. And my motto is, how do we get the best health for the most people for the least cost? And so that's what sort of drives me, right? A lot of it is just about that. It seems simple, but obviously it's not simple. It just may take a lifetime or several lifetimes, several generations to really do this at the global level. And so and like you said, I think each generation has to find their own answers for that, and the challenges are different. But I think a lot of the challenges now are about communication, just because it's so easy to basically spread lies. And so how do we make sure that we spread truth?
Yeah, I think
scientific truth.
Right. No, it's fascinating, just summarizing some of your comments across maybe the last 30-40 minutes, where you talked about the intersection of interests and relevance, and the intersection of precision as a researcher, and relatability to the common man, and the importance of collaboration to bring out, I wouldn't call it a counter narrative. It's almost the narrative that we need to build as public health practitioners, the narrative around truth, if you will. But thank you for sharing. That's very insightful, deep perspective, Dr. Galárraga. I know Sean had some questions along similar lines, and Nitya, I'm a little mindful of time as well.
Of course, thank you so much, Sean. Sean, I really appreciate it. Yeah, I'll try to be quick to be mindful of everyone's time, but I do have a couple of quick questions. First of which being, that many of us, myself included, were enrolled in Brown's online MPH program largely due to our passion for how to address structural and social inequities in how they impact healthcare. Many of us even some of us in the reproductive justice field. So, since we are looking at this as a potential future for a lot of us, regardless of discipline, what strategies can we as, emerging public health leaders utilize to help ensure equity and intersectionality are cornerstones in our future public health practice?
Yeah, I think that equity and intersectionality is just in everything that we do. I think that's just it. In my mind, is very similar to what WHO calls health in all, meaning that you have to think about health in all of the sectors, right? That you cannot think about environment without thinking about health. That you cannot think about the economy without thinking about health, because you're gonna mess up. And I think the same thing should be for equity and intersectionality, that there's always these aspects that we have to think about. The average is just not enough, right? We have to think, what happens at the 10th percentile and the 90th percentile. Just the mean or the median won't do. And so there's that issue of heterogeneity that we always have to be mindful. And yeah, I mean, this concept of intersectionality, of course, comes from sociology, and we learn to use it in public health, and that's very good. And I think that public health takes a little bit from everywhere, and I think that's good, that we are multidisciplinary and that we keep all these concepts in mind. And so the way I think about it is we're all working together against the enemy, which is disease, right? So I don't care, whether my colleagues are MDs or anthropologists or sociologists or economists or nurses or community health workers, whatever. We are together against HIV, or we're together against COVID, or we're together against X, against teen pregnancy. So we in that spirit, I think is how I think about these things. In public health, we're working together against disease, and we always have to be mindful of equity, intersectionality, because that's just part of making sure we're relevant again, that we're not just precise with our experiments, but that there is relevant, that there's change, there is positive change for the people, that there's very better health.
Absolutely. And I think that's really fascinating, especially what you mentioned, being relevant and remaining with positive change. So I have one last question in our last few minutes here. Circling back to what we mentioned earlier, when you mentioned that, there has also been negative change in addition to the positive change. There has been some backsliding and some, potential loss of programs. So, the climate around public health, especially in the COVID world, has been very divisive. So in the divisive climate currently surrounding public health, what do you feel is the biggest opportunity for the next wave of public health leaders to make an impact and to improve the health and well-being of our communities? And what do you believe should be the top priorities of us as future public health leaders to prevent further backsliding of principles and values among society, both in our own cultures and in our work throughout the world?
Yeah, I think that we need to stay away from politics. Politics is poisonous in public health. And so as public health experts, we need to, again, shine the light on what works and shine the light on what doesn't work in the most scientific way, and then, be able to communicate it clearly to everyone. So, for example, let me give you an example, right? So, as you know, I work in economic interventions, and I work, one of the things that we tested is, incentives for vaccination. Many of the programs, including RCTs, don't show that works. But if you look, for example, at, because of course people were having, doubts about it, and then, there's a lot of misinformation, and there's a lot of structural issues, especially for race, ethnic minorities. It's like, oh my God, the government is not trying to pay me. This must really be really bad. And so there was psychological issues that didn't work, and so we have to be mindful of the whole psychology of the public, not just the economic interest. However, that said, Ohio had something called the Vax a Million lottery. What they did, I think it was between March, sort of spring, early summer of 2021, they said, we're going to give $1 million every week for 5 weeks. And your lottery ticket is basically you signing up with evidence that you've gotten your first dose. This is something that came from I think a Republican governor, and they never did anything like this. In the footnote of one of the papers I read, and there's 2 papers I read, one in the American Journal of Health Economics, and the other one is the Journal of Health Economics. So very good methods, some of the top journals in the field. And one of the footnotes says that, the chief of staff has said, oh, this is a crazy idea. However, let's try a lottery. And so, like I said, to me, it doesn't matter whether it comes from the right, it comes from the left, it comes from a populist or not. If you have a good idea and it works, I'm for public health. I'm for more vaccination. I don't care who comes up with the idea, right? So colleagues basically used a method called synthetic control, and they used a method where they grab Ohio and they construct a synthetic control, meaning other states that you have a weighted average. So a little bit of Indiana, a little bit of other states nearby, is like matching, make it look just like Ohio. And that's one paper. And the other paper is with the counties. So the counties in Ohio that were exposed to the lottery, then they do again a synthetic control. They take counties from the nearby states that make it look just like these counties that were treated. And both papers, they were done independently and separately, and show very, very important effects on uptake of vaccine, right? So sometimes the best interventions, in this case an economic-based intervention, comes up from the most unusual places. And so let's just be open to solutions, and let's again be open to rigorous evaluation and shine light on what works, and hopefully stay away from that what doesn't work, right? So we know that individual incentives don't seem to work, and incentives that are too low, for example, the 40,000 lottery didn't seem to work. I think that was done in Maryland. And certainly stuff like, just have a beer, like I think they tried in New Jersey, didn't seem to work either. And so, try very different things and evaluate them properly, and be practical, right? How do we get the best health for the most people for the least cost, regardless of what political leaning they may have? And let's just stay away from politics, and let's just concentrate on what works in public health.
Absolutely phenomenal answer, and I think you really hit the nail on the head there. What works, at the end, what works? That's the important thing to keep the eye on, and keeping our eyes on our goal, which is really to make sure that everyone gets adequate health care. We have adequate interventions. So thank you so much and I'll pass it back to Nithya because I know we are coming up on time, but thank you so much, Dr. Galárraga. That was really insightful.
My pleasure. Thank you.
Yeah, thank you so much, Sean, Sham, and Dr. Galárraga, so much for this very insightful conversation. I completely agree with what you said about, it has to be relevant. And you've demonstrated that when you pivoted from studying about HIV in young population to then pivoting to MSM population, like we really have to see what's relevant. And that's a great learning, I think, for all of our students who'll be graduating soon, who may be thinking about what should I be working in as I go into public health next. And even what you said about healthcare workers who are volunteers. Recently, I remember, and Sham, you might know this too, the Anganwadi workers in India who are community health workers, about 100,000 of them went on strike because of the unfair wages, and they wanted to be paid more equitably. So it's definitely something to keep in mind as we think about how we can engage people at the primary healthcare level as well. So thank you so much, Omar, for your time and for being with us today and sharing all these wonderful insights. I think our students will learn a lot, even those who haven't been here today, who will watch this recording later. I'm sure they're going to have some wonderful takeaways from this conversation. And I think I will, if anybody reaches out asking to connect with you, I will pass along your information to them as well. So thank you.
My pleasure. Thank you so much for the invitation again. It was great.
Thank you.
Thank you.
Thank you so much, Dr. Galárraga. Thank you, Nisha.
Bye-bye. You're welcome.
Bye, Nithya.